hear other people talk about. Maybe it's questions that came up during the presentations or questions that might come up on tomorrow's presentation. It's okay. This is kind of and we also have set questions that people have sent in, but we want to start with your questions. So if you have a question, if you'd like to raise your hand, we will bring you the mic and get started.
I have a question in reference from Dr. Gillingham's conversation. You were talking about making sure their blood draws happen around the same time at every appointment. Is there a specific time? We don't fast for our appointment, so we usually eat breakfast, go there, have the whole appointment, and they're starving by the time we leave, and they do their blood draw right before we leave, so they're starving. Would it be better, or does it paint a better picture if they were to get it when they're not starving, or does it matter?
So that's a great question, and no, I would think that right before they eat the next meal, the fasting one, they'll be a little bit higher than in a fed state, but I think the consistency is it. So if you ate breakfast and it's always right before lunch, or if you go first thing in the morning and always get them drawn then, or I actually do know that a couple of the clinics in Mexico, it's always right 2 hours after a meal, so they have a sort of a standard protocol for when they draw the blood.
I have a question about the retinopathy study. Can you reiterate which genotype was more susceptible to having the higher hydrolyzed ACL carnitines, and for those patients, what you would recommend to mitigate that, or are we still looking for more information to know what to do in response?
So we'll start with the genotype. So people who have 2 copies of the common variant, G152HC, had the highest hydroxyacylcarnitines. And people with 1 copy, but then another private mutation, it was a little bit variable. So some of those people had lower hydroxyacylcarnitines and some had higher, and I suspect it has to do with that other allele, the other mutation. To your next question, what can you do about lowering those? During the day, the best way to keep them down is those small, frequent meals, certainly eating. But some of the variability in acylcarnitines is related to genotype, and you can't change that. So some of the variability, if it runs a little bit higher and you have 2 copies of that common variant, there's really nothing, that's just part of the variants that you carry, and that's not something that you're going to be able to control.
Now, let me follow up on that for a second, because in this country we don't use overnight feeds too terribly often in these diseases. We feel like we're able to get by with just waking up on a normal cycle for the first 4 months, and then maybe go 6 hours at 6 months is the usual. In Europe, they're much more aggressive with the overnight, and we have this argument all the time with the clinicians. They say, "Oh, it's much milder a disease here in Europe," and I'm not sure I believe it. Have you seen data on their incidence and developing those? I know. You'd think we talked about this previously, of the incidence of retinopathy.
Right. So we continue to have this debate, and Stephanie would be glad to know that in Kyoto we're actually having, in the dietitians meeting, a panel to debate this very issue. Should we be doing overnight feeds? And there'll be a dietitian from Australia, Austria, I think Denmark, UK, and myself, and we're all going to talk about how we handle it differently. And the problem is, I keep pushing those countries to publish their data. I haven't seen data, Jerry.
I think so.
There's no data out there to say that their eyes are better. So when I really drill in and I say, well, how old are those LCHAP patients that you're doing drip feedings overnight? They'll say 7. They'll say 8. I said, do you have anybody who's 30? Do you have anybody? And they'll say, oh no, we don't have any of those patients. And then I think, well, why? And to Alex's point, if you saw my graphs, vision is really...
Which I didn't.
Yes, you didn't. But vision is really, really stable. It's really normal and stable up till about 16. So I want to see their data when they did drip feedings as infants when they're 16, when they're 21, and we don't have that data yet. So I continue to push those dietitians to collect that data and publish it, but we just don't know. But it is different around the world, and in some places you get a diagnosis of LCHAD, you get a G-tube placed, and you get drip fed every night as an infant all the way up into elementary school.
So there was a question by someone who would like to remain anonymous, who was asking how high is like high with ACL carnitines, like when you're saying like these are really high, like versus, you know, do you know the number offhand?
Well, normal is really low. I think, you know, above normal is like 0.04. I think really, really high, I've seen a C16OH or a C16-1OH go up to almost 1. That's super duper high, but I think for most LCHA patients we see 0.3, 0.2, something like that, and I would consider that pretty high, and it would drop with the, am I saying numbers that make sense to everybody here, somewhere around there? For individual species.
So you showed that like LCHAD, like the ACL carnitines did not like rise during exercise, and you said you had some theories. Are you willing to share any of those theories?
Sure, I can share, and these are completely hypothetical, so I have no experimental evidence to back it up. But if you looked at the long chain in muscle in blood after exercise, like the C14-1 went up in LCHAD and the C16 similar to the VLCAD patients, but the hydroxys didn't come out. And I just think that perhaps that species not as soluble, doesn't get released from muscle cells as easily from a liver cell. But I would need to do some investigating to prove that.
Thanks for sharing your theories though. Other questions?
My daughter's going to go to the dentist for the first time on Monday. What is a way that I can talk to the dentist about talking about like cavities and everything, because she can't really go fasting and she's constantly getting those large carbohydrates in her, and like just the preventative, like do you have any suggestions for that type of thing?
It talks a little bit about dentists. I mean, I guess I was wondering if you were thinking how to talk to the dentist or how to talk to your kid.
How to communicate to the dentist, like, hey, Pamela has this rare genetic disease.
Yeah.
She just has lots of carbohydrates.
Yeah, I think that's like a great start. Be like, hey,
Preventative of brushing teeth, but
for sure. I think you should, explain exactly what you just did. She has a genetic disease. As a result, she has to eat pretty frequent meals, which often include a lot of carbohydrates, and unfortunately, sometimes those are sugary snacks, right? And just see if they have any other, preventative maintenance things. I think at the end of the day, maybe they'll say, oh, make sure she's brushing twice a day, perhaps earlier in life than other kids would. But you could at least ask them if they had other, other tips or tricks. I think you're already thinking about the right way, and I see maybe another parent would need to.
We also go to the dentist every quarter instead of once a year because.
There you go.
Yep.
I think that we may have missed the mark a bit with this. I did communicate, and Alex's dentist was aware of it. He had this notion that while we were feeding her in the middle of the night, that we were going to wipe out her mouth after that, but we did not. And so we failed as parents. So it's possible as she emerged into adulthood, she might have had a little work to have to do based on those. I don't know that we can know for sure that was true, but certainly 11 years of midnight feedings and all the things may have contributed. I do think communicating with the dentist is good so that they understand that you may be choosing the lesser of two evils in some aspect, but at the same time being part of the team. Apparently Alex needs the...
Oh, I'm sorry. I was just saying, I negotiate with my dentist now, because he's like, well, have you brushed after this? I'm like, no, I'm not gonna brush after every 5 meals I have a day. But we have a new system. I wake up, eat, and go back to sleep. He's like, nah, you gotta brush. I was like, nope, that wakes me up. And so, anyways, I just negotiated. I rinse my mouth with water, then I go to bed. So now it's a negotiation. So have fun negotiating with your dentist.
There's also high fluoride toothpaste sometimes they can add in, so you can talk to them about that if that's once they have teeth too, because like Christopher started going before he had many teeth at all, but it was still helpful to get to know the dentist, right? Like, and to know this is going to be a part of your life, like, which it should be a part of all of our lives, but some more than others. So, other questions?
Somebody this afternoon mentioned about propofol and about that, like it's okay for short-term use. Can you give us a better picture of what you mean for short-term use? Like, is that like just to reduce the sleepiness for the surgery, or just for like an hour surgery?
Yeah, I think so. I talked about that in my talk, though I also referenced Dr. Gillingham's paper. So I would say what I usually tell families is like fine for induction, like putting you to sleep, fine for a short procedure. I would say maybe less than a couple hours, but I wouldn't go beyond that. But if the person who wrote the paper has any other insights, I'm all yours.
Part of the issue with anesthesia in general, because you also hear people talk about CPT2 being a risk for malignant hyperthermia, and there are a whole list of anesthetics you're supposed to avoid with that. And first of all, the linkage is pretty iffy as far as I'm concerned. It's old literature for the most part, and it doesn't. I'm not sure I believe it, but the other issue is that when I talk to our anesthesiologists, and I say this is a patient with fatty acid oxidation disorder, just so you know the literature, and they do because we've had this conversation many times now. There's this risk in maybe a CPT2 deficiency. There's this concern about propofol because it's dissolved in fat. So you're giving a bolus of 40 grams of fat or something like that on an average bolus, an average dose. And what that convinced me is that their real risk of using a second line or less than optimum anesthesia for an otherwise relatively uncomplicated procedure. So I don't know whether that's 2 or 3 or 4 hours, but it's something where it's not like one of these all-night marathons that you see on the medical shows. And the risk of using a second line anesthesia and having a complication is higher than the theoretical risk that I tell them about using it because of fatty acid oxidation disorders. And so we've come to an understanding, and eventually what we've decided is that they should do what they think is best. There are some genetic conditions where you really don't want to use a volatile anesthetic because it does trigger malignant hyperthermia, but it doesn't usually in fatty acid oxidation disorders. So they're going to go ahead and do what they want to do. I tell them if you can avoid propofol, fine, but if the next best thing is way more dangerous, better use propofol. As was mentioned, Dr. Gillingham has published some case studies on safe use of propofol. And that way, and then we just make sure we know when our fatty acid oxidation patients are coming into the hospital for a procedure so that we can be ready for them. And that way we can give them D10, they get them tanked up and ready to go. They do whatever they can. The surgeons and the anesthesiologists don't like to use glucose intraoperatively, but we tell them they have to. And that's our line in the sand. And so far it's worked well. And I had this conversation the first time I moved to Pittsburgh, so we've been negotiating this for 20 years, and so far I think it's worked out okay.
I just add that for our paper, it was 2 to 3 hour procedures. And we actually calculated the gram load of fat and the amount that was infused in that time, and it ended up being pretty minimal. It was on the order of 10 to 20 grams, not
Okay,
so it was a small amount of lipid. And the thing I like about propofol is that when you turn it off, they wake up and they're eating a lot faster. So you have a longer time, you have a much shorter time to recovery back to eating normally after the
Okay, I have a question. So there was like a talk last year or the year before about a different metabolic condition that they did a study on where the body wasn't building antibodies to viruses and infections and all that. And I was just wondering if there are any new studies or ones specifically for FAODs on whether the body creates antibodies to these sicknesses.
So it creates antibodies to what?
Just like viruses and infections. Like, I don't know all these medical terms, but like.
Are you referring to the study Dr. McGuire did, maybe, on, because FAODs were in a study with Dr. McGuire about 10 years ago in regards to, the mini study, So I don't know if maybe that, because it was about infection, whether or not you can build memory to viral illnesses. He was looking to see if long-chain fatty acids allowed you to build memory to viral illnesses.
No new updates on that study, do you?
Nothing new on antibodies. We'll be talking tomorrow about the role of inflammation in fatty acid oxidation disorders, which is, I think, something that was underappreciated in the past, and it's starting to, we're starting to get a little bit more information about what might be causing it and what's actually happening, and therefore what sort of things we might be able to do to better treat it. So I'll talk more about that tomorrow.
I don't really know how to put this, but what about seeing FAD patients with like serious other like comorbidities like cancer? Like, what is treatment for that? Because I'm, as being like an older person, well, whatever, adults, these are things that are scary, you know what I mean? And how is that treated? And I'm sure it's a very case-by-case basis, but have you guys experienced that working with a patient with cancer or other, very serious illnesses? How did it go? What, anything you can tell us?
So try not to give my patient information away, but I have a patient with a fatty acid disorder and lupus that's very, very hard to treat because they need a lot of steroids for many lupus flares that we don't love because it increases her risk for rhabdo, all these other things. So it's trying to use a lot of different biologic agents. It's been very expensive, I think, for insurance companies, but doing a lot of letters to state why we can't just give her a dose of steroids every time just inflammation. But I do see that's really hard for her because it's two very complicated illnesses. They're fighting one another to treat. That it's definitely nothing written out there that we are just patching as we go. And I don't have a patient with a cancer, something of that aspect, but I think that we would search for the extremes to treat, to limit the stress on the body as much as possible as we provide the treatment to protect her fatty acid disorder.
Adult medicine doesn't care if they starve their patients, basically. And so I would be very careful, make sure you've got your medical alert device on, that you've got some kind of emergency notice in your medical record. Maybe carry an emergency letter with you. Have somebody advocate for you, because otherwise they might starve you.
I actually, personally, I never go to the hospital without, since I can't go to the children's hospital where I'm seen by a specialist, I always call them before I go to the hospital, and they actually call ahead, and they're expecting me, and they already know. Sometimes, I still try and give them the letter, they don't want to read it, and I'm like, no, but you gotta read the letter, you know what I mean? So,
It's a lot of uncharted territory. I think the one nice thing is that our community as metabolic geneticists, everyone's like 1 degree of separation or 2 degrees of separation from each other. And so when these unusual cases come up, everyone kind of knows who to reach out to and how to put all our brains together to help take care of patients the best we can.
And unfortunately, I think we're dealing with these situations on a very case-by-case basis, and we don't have the numbers to start to put it together in a larger
They will come in, they will see D10 running and say, well, she's not hypoglycemic. Because they're used to people with diabetes. And so, yeah, that's something we have to really kind of have to read the riot act about. You do not touch that IV without calling us.
So you mentioned steroids. Can somebody explain the why steroids is a bad idea? Because you mentioned you don't give your patients steroids.
So it's the steroids increases your metabolic demand, metabolic needs, and so when you already have a baseline sort of I don't know what the word is, sort of metabolic sort of dysfunction, where a little bit sometimes is, if you all know your bodies, where it's sort of teetering and it doesn't take much to push it over the edge into crisis, that we're adding something that is pushing you over that edge each time you take the medication, and we're pulling you back up. That's something that we don't want to give something that's going to stress out the body. There's many, many times that we have to for different medical reasons, and then it's just really, we work on making sure that you have a lot of extra calories. I think our dietitians are talking to you constantly to make sure you have a lot of calories on board if you need something like steroids for a reason that's indicated. But I know that they're, especially in the adult world, they like to throw steroids at a lot of things more often than we do in the pediatric world that can be more risky.
I just have a quick question about, on the steroids topic. Does that include topical steroids, like the ones that Hunter got this morning for his poison ivy?
No, so topical and things too that are really helpful are more like inhaled steroids for like stuff for asthma that aren't absorbed as much systemically are great. It's more like we're giving something that's a pill steroid that goes through your body, or really, really bad, something that's like a big bolus through an IV, so a big push of steroids in the IV that they sometimes give to help someone on a ventilator or something like that can actually like make things worse for our patients and make them need a ventilator for longer. So we just have to work with a specialist too. What's the risk benefit for that? But please get topical steroids. Itchiness is not good.
I will say it depends on the topical steroids, though. I think probably for poison ivy, like it sounds like Hunter's going to get us, like, it's a percentage in the topical solution, like, so he's probably getting like a 1 to 2% solution for a few days. I think I've had patients that have had very bad eczema and gotten things like 10 or greater percent steroids, and I've seen differences. But that's like over a long period of time with a higher concentration.
I have two questions. First one is, do you think that gene therapy, come over here, sorry. Do you think that gene therapy is going to be like a viable solution in the near future?
Someday.
Depends on what you call your future. So gene therapy has been just around the corner for 25 years now. And the reason that it's taking so long is that you figure out how to get around one problem and something else comes up. And you wouldn't know about the something else until you got rid of the first problem. There are ways of delivering genes that are safer now than some of the things that were used in the past. And there are some things that are being developed that are going to be safer than the things we have now. The difficulty with this all is knowing when to pull the trigger. If you look at the bad outcomes in gene therapy, this is just purely observational. I haven't done a study on this, but it always looks like it hits it's because of something bad happening in the organ that is mostly affected. So if you look at the Duchenne muscular dystrophy kids that died of gene therapy in the last few weeks, really, I think it is, both of them, they pulled it off the market because they died of systemic symptoms that looked like they started maybe with more muscle problems, more inflammation in the muscle. And then there was a couple of kids that died in the gene therapy where it was they were trying to treat the muscle, but it turned out that they had liver problems going into it that weren't recognized, and they died of liver failure. So, you know, the last thing that you want to do is take a patient that has a disease that is difficult, that is life-altering, but has been managed safely for as long as they've been alive, and give them something and suddenly alive. So I'm still working on gene therapy. I'm not going to stop trying to do the primary, you know, the fundamental basic science that will help us express those genes where they need to be. But I would really love it if the next big advance is a way of delivering this stuff without using a viral, hijacking a virus to do it, because that seems to be the biggest problem. If you can deliver genes very efficiently to the liver using something called lipid nanoparticles, think of it as soap bubbles, and it's much less inflammation, very easy to control, at least thus far, in the situations where it's been used. And we actually use this for the mRNA therapy that I was talking about, and that seems to work well. The problem is, a gene therapy based, trying with a focus on the liver is probably obsolete already. You shouldn't be doing that. But we can't get the lipid nanoparticles yet to the muscle and the heart. Whereas we can get a virus called AAV, which is a non-toxic. I mean, you all have it most likely in your lungs, but it doesn't cause disease in and of itself. And it's only when we infuse these huge quantities that you need to use for gene therapy that it gets into trouble. It triggers a response to the body. Hopefully, what will happen there, and I'm working with a very smart lipid chemist at the university that's trying to design new lipids that will target heart, muscle, kidney, whatever organ you want, and so that's what to keep an eye on. It's not only just expressing the genes, but how you're delivering them to the cells that's important.
Thank you. Sorry. My second question is, our son is 12. He had a lot of hospitalizations when he was younger. He's been relatively okay, and now he's in sports and all of those kinds of things, and he's tall and fairly athletic. And so we're just concerned, you know, we want to make sure that we're doing the right thing and we have an awesome doctor who's on the stage. And I just wanted to get an idea just from you all in terms of, because I think they just started testing like 5 years before he was born, the newborn screen. And so I know that there's people out there who probably have it and don't realize it. And so I'm just trying to figure out, because our concern, and I think I've talked to some of the parents here, is that, you know, you don't want to push them too hard. You want to make sure, but they also really want to compete and do all these things. And I'm not sure how we can try to balance, and like if we should say, okay, well, you're doing fine, or you haven't had any issues in a while, but you have this concern that maybe just one day he's just, you know, he hasn't had heart issues, he hasn't had these issues over time, but this one time next week, you know, something could happen and you have you know, emergency. And just to kind of reassure us, or, you know, try to figure that piece of it out for somebody that has been relatively healthy for the last, you know, 7 years or so.
We're going to let you talk to the kickboxer.
So I'm a big fan of prevention and also looking at things with a different lens through a different specialty. So as a physical therapist, I look at mobility and strength in a different way than some of the doctors do. Someone like that, I would say, maybe come in, and how I describe it to patients is you bring your car in to get a quick tune-up, right? So in a few months, maybe twice a year, consider going to PT and doing a little PT tune-up. It won't be as extensive a program as you might have if, say, you had a hip replacement or you had some other surgery. It may just be, okay, for 6 weeks or so, we're going to look at whatever your focus is. maybe you feel like you need to build up a little strength for whatever sport you're competing in, maybe your focus is endurance. We'll do different tests that look at how you're doing compared to age-matched peers, and look at things like, okay, if cardiac is a concern moving forward, how can we keep track of your progress, and what can we focus on now? So that can be really preventative. It can also help teach ways to monitor yourself while you're doing exercises and have a little more insight into your body as you go into competitions.
It's clear that no matter what kind of muscle disease you have, it's worse if you become deconditioned. And so this is why I talk to my patients about doing 20 minutes of mild to moderate aerobic exercise every day, at a minimum. And the maximum is well, all right, I'm going to rule out marathons, okay? But I don't know what between 20 minutes of mild aerobic exercise and marathons is right for any individual. And so this really is, there are things, Melanie's done some very nice studies showing how best to give triheptanone or MCT oil before exercise. We can bring her in on this. You know, just making sure that while he's exercising, you're doing all the things that you can to keep it safe. So hydrating, having some sports drink with some carbs in it or some complex carbs. Make sure that's going on during the practice or the game. And it does matter which disease you've got and what flavor it is. You know, if it's mild, moderate, or severe, as to how much your risk you're going to have by pushing yourself to extreme. I worry about extreme, but I don't worry about exercise. You want to talk about your...
Yeah, so we have done some studies where fueling exercise before with, I would recommend like a carb MCT or carb C7 mix before exercise really helps. It lowers the heart rate for the same work performed, so you get, your heart has to work less hard during exercise when you've got the right nutrition on board. But I agree, I think we've learned over the years that deconditioning is by far the worst, so staying active and encouraging that. The trick as parents is going to be, and I can't answer this for you, you're going to see how it goes, is walking that tightrope of allowing them to compete and enjoy the sport and not push so hard that it sends them into rhabdo. And that line is probably different for every person. I do think, and other parents might comment, that having a great relationship with the coach and being able to talk about what are his limits and when to take breaks and be allowed to have some hydration and snacks is really key. So, but I think sports are great and it's good for him in a whole lot of ways.
I just want to put a plug in that tomorrow there's going to be a session just on sports, and so and Dr. Gillingham has led a couple sessions that are pre-recorded too. So there's a lot of great information out there, and then talking to parents because we all have those quick tips and tricks and stuff like that as well.
To kind of follow that up, we have the same, like, I have seen that deconditioning and the conditioning makes the biggest difference, right? Once they're in shape, it's like a different kid. When they're not in shape, they're not resilient to any activity at all. So during the sports season, great, he has practice every day, he has friends to do that with. But then, like in the winter, when he doesn't participate in this organized sport, how do you you have any ideas for motivating a kid or getting them, like he can go lift weights by himself in the basement, but it's not the same as going to soccer practice, right? So how do you get some kind of a program or routine for a kid to stay conditioned?
I love having her sitting next to me. I get to pass off all her questions.
Try to make moving a family affair, for one thing. Even in the winter, you can take a walk after dinner. You can go bowling instead of to the movies. Trying to trying to make moving a family affair can be helpful rather than being singled out and being told to go exercise. I had a patient who family went on a long trip to Europe, and they took, where people walk a lot more in Europe, they took a wheelchair, but said by the end of the trip, they were hardly using the wheelchair because as her tolerance built up, she just did better and better.
I agree with that. I feel that even small steps do add on to each other. So little things, for instance, like usually we go to the grocery store at least once a week, maybe each time parking a little further away, not the closest spot possible. But everyone's different. Everyone has different things that motivate us. Some things to think about are some kids are really driven by technology and they enjoy things like Apple and some of the other companies. They have something where you can see how many steps your friends have taken and you can have a weekly competition. So some kids really enjoy that. And they have features like, oh, I can do a 15-minute HIIT workout and start playing around with different features using things that they already engage with that they can then share it with their friends and get that social connection. I would also say maybe that would be a good time to consider doing a physical therapy tune-up if it's between sports and you have different goals that you'd like to work on. And also your therapist can maybe be a good community resource for you. I have a booklet that I share with families. I try to have that conversation of, okay, what are our goals? What are we trying to get back to? Or is there something new that you want to try? Do you want to try horseback riding? Do you want to talk about swimming? I'm here to help you do what makes life exciting for you.
Sometimes I tell families if kids don't tolerate a fitness monitor or if they're cheating with it, putting it in a sock in the dryer or whatever, put it on mom. Because you're the one that says, hey, we're going for a walk now. And you're the one who says we're going to the park to play. So if the kid can't wear it, you can.
I've learned to be I've been a big fan of, an increasing fan, I guess I should say, of how our physical therapists can help us since meeting Pamela a few years ago. I always viewed physical therapy as something that you did to recover from something bad. So I really like the idea of a physical therapy tune-up where you're just going in and number one, you're getting an evaluation of what you can and can't do. And that's what we're doing as physicians. We're telling you, based on this test, what you can do. And the tests that physical therapists do are different. They're watching you do things and they say, okay, we can improve this here, we can improve that there. I've been trying to incorporate that more and more into, especially my adolescents and young adults, because if the muscle disease is going to start getting worse, that's when it's going to happen. The young kids, they run around like crazy, and you almost never need to worry about them. But then you start turning into a teenager or a young adult, and you've got all these other things that are on that take away your time, and I'm as bad as the next person. By the end of the day, if I'm too tired, the thing I skip is my exercise. So having somebody who helps you monitor that is a really good thing.
I wanted to go back to the inflammation question, or not the inflammation question, but the illness question. So circle back around a little bit to the earlier question and pose it a little bit differently. So I think a number of families have experienced, it seems like, especially when our kids are smaller, and it might not be limited to when they're smaller, that they seem to get sick over and over and over again. Stomach bug goes through the class, and they get it a second time go around, or it seems like maybe after a cold they always end up with a sinus infection. And so I'm wondering if you guys can kind of talk to that or your understanding of that, and if you're experiencing a lot of secondary infections, have you ever encouraged patients to get their titers checked to see if they're actually building immunity? That's kind of what Dr. McGuire was looking at. What are your thoughts around some of that? Or or clinical experience? Have you noticed that, like, because I know as a community, it is an experience.
Well, the one time we really noticed was post-COVID, because when everybody else and the ER doctors and the ICU doctors were out of their minds, we were just sitting pretty, because when you put our patients in a bubble, they don't catch anything. But as soon as the isolation broke, they started catching everything. So that's the one time I really did notice, and it wasn't just fatty acid oxidation, it seemed to be like all of our patients.
Yeah, I haven't tended to see like frank immunodeficiencies or, where people's bodies really aren't fighting infections appropriately. In little kids, it's just that we expect kids to get like 6, 8, 10 colds a year. I just lived that life myself thanks to the young gremlins in my house. So I think some of it is just that you notice it more when you have to pay extra attention when your child is ill, right? Like your neighbor next door, their kid's got a runny nose for the 10th time. They're just living their life. You're, on high alert. Are they eating? Are they drinking? Are they having a fever? Do I need to call my metabolic team? And so I think some of it is just the nature of being a young kid, plus the layers of extra care that you are providing your family.
My question's about, especially, I'm so sorry, I don't remember her name, but with like athletes and being exercise, what do you guys as physicians see as like creatine monohydrate after exercise, because that's supposed to be a supplement that's supposed to replenish the muscles and repair the muscles, and also like taking a supplement such as NAD that would help also with the cells and the mitochondria. Is there any studies done on that?
Are you talking creatine? Is that what you're
Yes,
saying?
yeah,
Okay.
sorry.
Yeah, I did talk about that last year, and I didn't know much about it and dug into the literature. In athletes, it probably is the one supplement that does have pretty solid evidence that there's some benefit. There are no studies in fatty acid oxidation.
Well, like just looking at the supplement as a whole, like if it helped with athletes, do you think it would benefit?
It's certainly possible. It's certainly possible. We have no evidence that
The one muscle disease where it's been used has been the other group of disorders that mitoaction works with, the respiratory chain deficiency. And there's still a fair amount of controversy in that field, but the evidence there is a little bit better. There are two ways to use it. Some individuals just take it every day, and they say it makes them feel better. And but there especially one really strong proponent who's done some good clinical research to back him up, that says it works best if you're doing this in bursts, that your body sort of accommodates to it in some way, so that if you're having a bad stretch, you can do a week or two of it, but then you have to be off of it for another 2 to 4 weeks. So yeah, that's more. And I agree with Melanie. I think that there's all of the things that we see out there. This one intrigues me the most. I'd love to do a clinical trial. Maybe if we get our NIH-funded informed version where we have some money to do some work, it would be a great one to do. You mentioned NAC, NAC. I can tell you that.
NAD.
I know, I took the supplement, it's like NAD plus.
Oh, NAD. Yeah, okay.
it's like nicotine oxide or something like that.
Yeah, there's a new one out there now. There's a new one out there now that the problem is it's kind of like whack-a-mole. You work through one and then the next one comes up. It's being used in the respiratory chain community as well. And right now it's in the phase where everybody's trying it. That's all I'll say. I don't think there's any evidence yet that this new version is the right drug to do that. NAD is the cofactor that LCHAD uses to do its job, and the NADH, which is what LCHAD makes, funnels into the respiratory chain. And so this is being used as this makes better, more fuel for the respiratory chain. The LCHAT, there may be some specific benefit. It's absolutely worth studying, but I would really love to study it rather than tell you, well, hey, go do the trial and know what's going on. You know, it's a bad way to do but ultimately, you know, it's hard to get money to do these things, so sometimes you just crowdsource it.
Have you guys seen in any consistent way patients in our community that have difficulty with attention deficits or deficits with executive functioning?
I haven't really noticed that. Have you?
I mean, this is a conversation that I've been having with some of the folks. We're not in this room, unfortunately. And I think it's something we need to start exploring.
I hear a lot from families, so I just wondered.
Yeah. I think the executive functioning is gonna. I think it'll be interesting if we went further with that. Just based on what we know from other metabolic communities, that it's. I think we have a lot of young adults here who actually have successfully made the transition to college and independent living. But for a lot of the other folks that we see in our clinic, like that transition out of high school into college is very challenging. And I think it's because of some differences in executive function.
What's it that did the clinical trials? Was that you, Amanda?
Pardon?
Was it Amanda? Was it you that did the clinical trial? Who did clinical trials?
Oh, Beth.
So you were talking about natural history studies. Yeah. And I think this is so critical. We know what we know. We don't know anything else. And that seems a little silly to say, but it is a really important truth to internalize. And so I can tell you what I see and what I don't see, and everybody on this panel can tell you that. But unless we can put the data together in a natural history study that lets us do this, capture all of your data in a more rigorous way, it's going to be tough to answer. There also are a lot of factors here. So were you ever so sick that you were on ECMO, for example? Well, there's a lot of information that says people who have been on ECMO actually may have some longer term effects from it. How does that play in to our kids who are on it for a short period of time because they have heart failure and then they come back? Don't know. It's not, it hasn't happened often enough, or at least it hasn't been captured often enough to know whether that's a real thing in fatty acid disorders.
And I think it's one of the special things about these spaces that we have together, because we've talked throughout this conference about the importance of sharing our stories and us being able to share with clinicians about our experiences. And then I know last year we had a conversation about rhabdo, and a patient asked, is it a thing like when your eyes hurt with rhabdo? Because every time like my kids' eyes hurt when they go into rhabdo, and the clinician was like, no, and then you start seeing parents' hands raised and say, my kid too, and sometimes these conversations create connections. We're able to connect some dots and ask questions and ask different questions and walk alongside you guys. So thank you so much for all of your hard work, for answering all of our questions tonight, for being here and your presentations. Let's please give them a warm round of applause.